There is a version of your face that has been quietly pulling away from the other side for somewhere between 10 and 30 years. And the explanation that most people receive from dermatologists, from skincare brands, from the people who study aging professionally does not account for it. Let us eliminate the obvious candidates one at a time. Sun exposure. Possible contributor to the difference, certainly. The left side of a driver's face in North America gets more UV, and studies in photo damage research show this cumulative asymmetry in populations who spend significant time in vehicles. But UV is an environmental factor. It does not explain the asymmetry in people who have never driven regularly, in people who wear high SPF daily, in people who live in overcast climates where bilateral solar exposure is essentially equal. UV touches both sides of your face. If UV were the primary driver of asymmetric aging, the pattern would be predictable and consistent across populations. It is neither. Genetics. Your genetic code does not differentiate between the left and right sides of your face. The instructions are bilateral. Genetic expressions of aging, collagen production rates, sebaceous gland density, telomere shortening, operate systemically. They do not preferentially target one cheek, one jowl, one orbit. Genetics is a real aging variable. It is not an asymmetry variable. Sleep position. This one is more interesting. The pressure of lying on one side does compress tissue, and sleep position research does show some correlation with asymmetric facial tissue changes over long periods. The problem is magnitude and directionality. Most people change position multiple times per night. The people with the most dramatic facial asymmetries are not the most consistent single-side sleepers. And the specific pattern of asymmetry, the jowling, the orbital descent, the nasolabial deepening, doesn't map cleanly onto sleep pressure distribution. Something else is loading the tissue more continuously, more directionally, and for far more hours per day than sleep. Stress. Stress is bilateral. Cortisol does not prefer one side of your face. So we have eliminated the primary candidates. All real, all contributing. None of them can explain what you can see in a mirror if you cover one half of your face with a piece of paper and then switch sides. One side is older, sometimes dramatically. The question that the conventional framework cannot answer is, why? What most clinicians are not trained to ask, and this is not a criticism of individual clinicians, it is a structural observation about how specialties are organized, is what forces have been acting on your face for decades from below. Not from outside, from below. There are two models for how faces age, and they have been running in parallel in the medical literature without ever being formally put in conversation with each other. The first model is the one you know. Aging is primarily a systemic, passive process. UV radiation damages dermal collagen over decades. Hormonal changes in midlife reduce collagen synthesis and increase skin laxity. Oxidative stress accelerates cellular senescence. Gravitational force works on soft tissue uniformly. Time is the primary variable. Lifestyle and environment modulate it. This model is well supported. It is not wrong. The researchers who have built careers on it have contributed something real to our understanding of skin aging. But it is a model that was built to explain the face from the outside in. It looks at the tissue and asks, what is damaging it? What is depleting it? What is pulling it down? The second model has been living in orthopedic literature, in fascial anatomy research, in physical therapy journals, in the clinical observations of body workers who have spent decades with their hands in human tissue. It asks a different question. What forces are acting on this tissue from the skeleton outward? What is the mechanical history of this person's posture? And how has that history shaped what we're seeing? These two models are not in conflict. They are describing different variables. But Western medicine organized itself into specialties: dermatology for the face, orthopedics for the spine, rheumatology for connective tissue, in ways that made it structurally difficult for these conversations to happen across disciplines. The face became a dermatological organ. The neck became an orthopedic structure. The boundary between them, for billing and training purposes, was clean. Biology does not respect that boundary. There is a framing I want to bring in here that comes from a long way outside Western medicine, and I want to be precise about what I'm borrowing and what I'm not. In traditional Chinese medicine, in Ayurvedic practice, in indigenous healing traditions across East Asia, South Asia, and parts of Africa, the face has never been understood as a separate organ. It has been understood as the terminal expression of the body's postural and energetic organization. Facial mapping traditions, which have genuine cultural specificity and should not be homogenized, share a common underlying structural assumption that what appears in the face reflects organizational patterns in the tissues and structures below the face. You do not have to accept the metaphysical frameworks of any of these traditions to notice that they converged on something anatomically accurate. The face is the surface expression of the neck, the shoulder girdle, the thoracic spine, and the postural organization of the whole body. Thomas Myers, whose anatomical mapping work in Anatomy Trains changed how movement therapists understand fascial continuity, documented something that anatomy students had technically known for decades, but that nobody had organized into a clinically usable framework. There is an unbroken fascial network running from the plantar surface of the foot to the gallia aponeurotica, the fibrous sheet that covers the top of the skull and connects downward through the temporal fascia to the face. This is not metaphor. This is dissection room anatomy. The superficial front line, the lateral lines, the superficial back line, these are continuous tensional structures that transmit load from the foot to the face without interruption. What this means, in structural terms, is that a chronic deviation in your posture, a shoulder that sits higher on one side, a head that tilts consistently toward one shoulder, a thoracic spine that has developed a rotational preference after years of reaching toward a dominant hand, transmits tension asymmetrically through the lateral fascial lines all the way to the facial tissue. The face doesn't know it's a dermatological organ. It experiences the tension coming up from below, and it responds to it the way soft tissue always responds to sustained mechanical load. It remodels. This is, I should be clear, a well-established principle in connective tissue biology. Wolff's law, typically cited in the context of bone, has a soft tissue equivalent. Sustained mechanical force reshapes connective tissue over time. This is why orthodontic retainers work. This is why the connective tissue of elite athletes differs measurably from that of sedentary populations in the same age group. It is why Dr. Carla Stecco's dissection work at the University of Padua showed that fascial density and organization vary predictably with loading history. The fascia remembers what the body has been doing. The more loaded side of the body carries denser, less mobile fascia. The less mobile fascia restricts lymphatic drainage. Restricted lymphatic drainage means inflammatory byproducts accumulate in the tissue. Accumulated byproducts accelerate collagen degradation. Restricted mobility in the fascial layer reduces the mechanical stimulus for collagen synthesis. You are simultaneously accelerating breakdown and reducing replacement. The tissue thins, loses its spring, loses its capacity to return to resting position after displacement. Gravity does what gravity always does when resistance decreases. That is why the compressed side looks older. Not because time is acting on it differently, because mechanics are. An oil painting ages differently across its surface, depending on the tension in the ground layer beneath the paint. The craquelure, the network of fine cracks that develops in aged canvas paintings, follows the direction of underlying stress. A conservator can read the painting's mechanical history from the pattern of its cracks. The same logic, adapted for biology, not art, applies here. Compressed, restricted fascial tissue on one side of your face is not decorating itself randomly. It is telling you something about how the body has been organized below it. Now let me be specific, and the specificity matters here, not to frighten you, but because vague claims are useless. Research on facial asymmetry in identical twins, individuals with identical genetics, often comparable UV exposure histories, has been particularly instructive. Work published in the context of facial plastic surgery research, examining twins with different occupational postures, found measurably greater unilateral ptosis, deeper nasolabial folds, and more pronounced orbital descent in the twin with the more chronically asymmetric postural load. Same genome, same family environment, different mechanical history, different face. This is the kind of finding that tends to disappear into specialty journals, because nobody whose professional identity is organized around systemic aging factors has any particular incentive to amplify it. Dermatologists are not trained in postural assessment. Orthopedic surgeons are not looking at facial soft tissue. The finding sits there, accurate and largely unremarked upon. You now have context for it. That changes what it's worth. The question worth asking at this point, and I want to be direct about how to answer it, is which side of your face is the compressed side, and what is the postural pattern that created it? 3 indicators. These are not a formal diagnostic instrument. They are orientation points. First, stand in front of a mirror and look, genuinely look at both sides of your face without judgment. The compressed side typically shows earlier and deeper nasolabial fold definition, slightly more pronounced jowling or orbital heaviness, and a subtly flatter, less 3-dimensional quality to the cheek. It may not be dramatic, but it is usually visible once you know what you are looking for. Second, look at your shoulders. The side with the chronically elevated or anteriorly rotated shoulder is almost always the side with greater fascial tension in the lateral line. The shoulder elevation you have been attributing to stress, or to your bag, or to nothing in particular, is a postural pattern with a 30-year mechanical conversation with your face. Third, notice which side you favor when you hold your phone, when you tilt your head during long calls, when you turn toward your screen. The accumulated hours in those positions, and we are talking about thousands of hours across a decade, are load-bearing time for your lateral fascial system. You do not need all 3 indicators to confirm a pattern. 1 is usually enough to orient. 2 or 3 make the pattern unambiguous. The protocol that follows is graduated for a reason. The reason is that fascial tissue is not muscle. You cannot stretch it hard and fast and expect useful results. You coax it. You apply sustained, gentle, directional input, and you wait. The timeline is weeks to months, not hours to days. Level 1, start tonight. This takes 2 minutes and requires no equipment. Sit or stand in front of a mirror with neutral lighting. Without correcting anything first, simply observe your resting posture. Notice, is one shoulder higher? Does your head tilt even slightly toward one side? Is your chin carried forward of your sternum or roughly above it? Take a photograph if you want a record. You are not trying to fix anything tonight. You are establishing a baseline. The value of a baseline is that it makes future change visible. Invisible change is the kind people abandon. Level 2, daily practice, 5 to 7 minutes. You can start this tomorrow. The target is the lateral line on your compressed side, the fascial chain running along the side of your body from the foot through the hip, the lateral trunk, the neck, to the temporal region of the head. You are not treating your face. You are releasing the line that loads your face. Begin standing. On the compressed side only, raise your arm overhead and perform a gentle lateral side bend away from that side. A true lateral bend through the trunk, not a forward lean disguised as a side bend. You should feel the stretch from the lateral hip up through the lateral rib cage and into the side of the neck. Hold for 45 to 60 seconds. This is not the stretch where you feel a dramatic pull. If you feel a dramatic pull, you are using muscle, not fascia. Back off slightly until you feel a diffuse, spreading sensation. That is the fascial tissue receiving the input. Follow this with a seated neck lateral stretch on the compressed side, ear toward the opposite shoulder, chin level, no rotation. One hand anchors the opposite shoulder gently downward. Hold 60 seconds. breathe normally, repeat once. This is the minimum effective dose. 2 positions, 5 to 6 minutes total. The research on fascial remodeling suggests that daily sustained input produces measurable changes in fascial density and mobility within 6 to 8 weeks. The rate of visible change in fascial soft tissue will lag behind the mechanical change. Give it 3 months before you evaluate. Level 3, structural habit modification. This is the layer that determines whether levels 1 and 2 compound or stall. For screen work, screen height matters more than most people appreciate. A screen position below eye level, which describes most laptop users, most people working at a desk without a monitor riser, produces a chronic forward head posture that loads the anterior fascial lines and creates secondary lateral tension asymmetries. Raise your primary screen to eye level. This single change, sustained over months, produces measurable spinal position changes in cervical postural research. For phone use, if you cannot eliminate prolonged phone use, and most of us cannot, bring the phone to face level rather than bringing your face to phone level. The difference in cervical loading between these 2 positions is substantial. Your neck does not distinguish between looking at my phone and sustained load-bearing posture. It only knows the position. For sleep, if you are a consistent single-side sleeper and that side corresponds to your compressed side, this is worth addressing. You do not need to become a back sleeper overnight. A body pillow placed at the appropriate height to prevent the shoulder from compressing inward on the dominant side is a lower barrier intervention. Full back sleeping, if you can achieve it, removes the lateral loading entirely during your 6 to 8 hours of overnight tissue recovery. These 3 levels are not intended to be completed simultaneously. Begin with level 1 tonight. Add level 2 when the audit from level 1 has given you a clear sense of your pattern. Add level 3 modifications incrementally over the following weeks. The cumulative effect of all 3 maintained is what produces visible change at the tissue level. Before we close, the diagnostic questions, 3 of them. Your honest answers tell you where to begin. First, when you look at both sides of your face in a mirror, is the difference noticeable to you, or do you have to look carefully to find it? Noticeable without trying means the mechanical pattern has been active for a long time, and level 2 is your primary focus. Hard to find means you are earlier in the process, and level 3 modifications, the habit changes, are your leverage point. Second, does one shoulder sit measurably higher than the other, or does one sit noticeably further forward? If yes, your lateral line tension is already established, and the tissue work of level 2 is non-negotiable, not optional. Third, in the last 5 years, have you had any experience with chronic neck tightness, tension headaches, or jaw discomfort that has been explained to you as stress? These are the same fascial system expressing the same chronic load through different tissue. If yes, you have more information than you thought you had about where your postural pattern is centered and how long it has been there. Your answers are your starting point, not someone else's protocol, yours. If you find this kind of analysis useful, the kind that starts with what the evidence actually shows and ends with something you can do with your own body, there is more of this here. Not every video goes this deep. The ones that do are the ones worth staying for. We began by eliminating the explanations that do not account for the asymmetry. Sun, genetics, stress, sleep position, all real, none of them sufficient. What remained after the elimination was mechanics. The mechanical history of your posture, transmitted through a continuous fascial system that your dermatologist and your orthopedic surgeon have never been formally trained to discuss together, has been writing itself into the soft tissue of your face for years. The side that looks older is not the unlucky side, it is the loaded side. And load, unlike genetics, is something you can change the distribution of. That distinction between what is fixed and what is mechanical is what you are walking away with. It is smaller than a revelation and more useful than one.